Hi, Joe. Thank you so much. I'm going to try and share my screen, so bear with me. So I'm today going to be talking about the different types of tumours for ocular tumours, the different types of treatment for ocular tumours and some of the complications that can happen following these treatments and some of the solutions to those complications. So as Joe mentioned, I'm one of the consultants at the Liverpool Ocular Oncology Service. You may know that ocular tumours are regarded as highly specialised illnesses because they're so rare. So there's only 4 centres in the UK that deal with these tumours, Liverpool being one of them. Liverpool was set up by Professor Tomato a number of years ago, who has since left to work in other areas, and now it's myself and Professor Hyman in Liverpool at the moment. We're very lucky in Liverpool because we have quite a good subspecialist team with a good multidisciplinary approach to our patients. So we've got Professor Copeland, who's excellent with her pathology, Doug Errington and Ernie Marshall, who work on the oncology side, and Stephen Fennick, who's a liver surgeon. So of the 600 odd cases of ocular melanomas that are diagnosed every year, we probably see just under half of them, 250 to 280 or so in Liverpool. So we have quite a wide experience on treating these tumours. I'm going to start off with the more uncommon conjunctival tumours, just because they're not talked about as much as the other intraocular tumours, and then we'll come on to the intraocular side a bit later. There are 3 types of conjunctival tumours, and we'll start with the most common, which is the melanocytic ones. And so the most common conjunctival lesion is a nevus, which is a benign condition. It's like a mole or a freckle on the skin. You can also get them on the eye. And usually they don't need any treatment at all. You just keep a watch on them. But just like any mole or freckle on the skin, they can grow and change into something more serious like a melanoma. And so we do recommend that they are watched at least and not just disregarded. That can be done at the optician, or it can be done within the hospital setting. Some patients prefer to have them excised and removed, either because they don't want to worry about being monitored in the future, or because they don't think they like the look of it, or because it's grown a bit and we're a little bit worried. And so sometimes we excise them, but usually not. They can come in all sorts of shapes and sizes, and it's sometimes very difficult to differentiate a nevus from something more serious. And then you kind of move on to slightly higher grade illnesses. We call them conjunctival melanocytic intraepithelial neoplasias, which is a bit of a mouthful, but for ease, we would call them Siemens. This is what used to be called primary acquired melanosis, or PAM. That's a bit of an outdated kind of name nowadays. And essentially, these are melanocytic cells or pigmented cells that are abnormal. So they're not cancer lesions, but they're on the way or on the journey to become cancers, if that makes sense. And so our main aim for these types of lesions is to stop them ever becoming a melanoma. And so either we can watch them and see if they progress or grow. If they are growing or they look a bit nastier, like this one here in the bottom right, that we might take a biopsy of it to see how abnormal those cells are and how close to being a melanoma they are. And so these ones, we might take a little snip out of them and look into the microscope and have a look. And realistically, the best treatments are topical chemotherapy. That means eye drops, but they are chemotherapy eye drops. And just like any other chemotherapy, fortunately, they just go on the eye and they don't go into the rest of the body. But just like any other chemotherapy, they can have side effects. And the main side effects for all of these treatments is the side effects that they have on normal tissue. So although they're very good at killing off abnormal tissue, they also kill off normal tissues as well. So these are the 2 drugs that we use, the mitomycin and interferon, and they work very well. You can see how much this has changed over the course of their eye drop treatment, and again, this one as well. So they work very well. And then we move on to conjunctival melanomas, which are invasive cancers, really. They, again, can look very different, and no one size fits all. Along with chemotherapy eye drops, we do also treat them with cutting the lesion out, and also with radiotherapy as well. And so this is a lesion that was removed, treated with radiotherapy and with mitomycin eye drops. And again, this is another one that was removed, treated with eye drops and radiotherapy. So this is a plaque radiotherapy. We'll talk about what plaques are in a while, and they work very well. The side effects are really about local tissue. And so because they are quite toxic eye drops, they can cause a lot of inflammation, a bit of pain. Sometimes the eyelid gets a bit droopy, as you can see here, and that doesn't always settle once the eye drops have stopped. And that can be problematic to the extent that patients really can't carry on with those eye drops, and then maybe we try something a little bit gentler. Just like with chemotherapy, like I mentioned, the destruction of normal tissue with normal chemotherapy, so the gut and hair, and that's why you have problems with diarrhea and hair loss with systemic chemotherapy or chemotherapy through your bloodstream. With eye drops, it sometimes has side effects on the cornea or on the conjunctiva, which is the skin over the surface of the eye. So you don't produce as many tears, you don't produce as many oils as you normally would to protect the eye, and the cornea sometimes suffer. And we call these ocular surface problems, where the surface of the eye isn't quite as lubricated, isn't quite as even as it should be, and that can cause problems with not just vision, but also it can be quite uncomfortable. The treatment for that really is eye drops, lubricants, artificial tears to try and replace the tears that are lost. Very rarely you can move on to things like stem cell transplants of the corneal area, or even corneal grafts if it gets very, very bad. The problem with all of those treatments is that if you then need drops again because there's a problem with tumour coming back, then they can have even more side effects on a corneal graft, for example. Recurrence rate is another issue, and that's why we monitor patients lifelong. This is a patient who had this melanoma removed, which responded very well, but a few years later we noticed that they had a recurrence up at the top. And sometimes they can be very, very subtle, and so we do watch patients very closely, and that's what all the photos are for when you go to ocular oncology clinics. So this is a melanoma that was excised, and then a number of months later it looks pretty good, really. But if you look really closely, you can see that little blob there grew over time, and that's a little recurrence. And sometimes if there's a little recurrence like this, you can essentially do the same thing again, cut this area out, put a plaque on top, and treat it with drops. The other type of tumour that we treat is epithelial tumours, so carcinomas rather than melanomas. They come from the conjunctiva itself. So these are benign lesions, just like nevus, but kind of the squamous cell side of things. So papillomas, they're basically warts, they're benign, they don't really do anything, but they can cause problems like bleeding or irritation, especially if they're kind of trying to protrude out of the eye like this. They can catch on the eyelids and they can be problematic. Again, we can leave them or cut them out. We can treat them with eye drops, usually interferon, which is a bit gentler, and again, the side effects are similar. This is like the next stage on, just like the Siemens, you've got CINs, which again are abnormal cells, but they're not cancer cells yet. And again, we can do exactly the same. Eye drops, remove the lesion if we can. Something like this, which is quite a wide area, will probably just remove some of it, but the eye drops do most of the work. And then squamous cell carcinomas, they are eye tumours, invasive tumours, and so they are cancers. It's very similar to the melanomas, but they have kind of a slightly different profile. They don't metastasize as much as the melanomas, but the treatments are essentially the same. So excision, plaque, and eye drops. And again, it works quite well, but the side effects are very similar. If there are big areas, unfortunately, the eye does require the conjunctiva to survive. And so realistically, if there's such a big area that we can't repair that area, then sometimes we need to undergo accentuation, and that's quite an aggressive surgery, but realistically that's the safest form of treatment for some of these larger tumours. So again, the side effects are the same: ocular surface problems, problems with the sclera, problems with the conjunctiva, and again, the treatments are generally eye drops or stem cell transplants. And then the last type of conjunctival tumour is lymphomas, really. Lymphomas, we generally tend not to treat from an eye point of view. They generally are signs of lymphoma somewhere else. And so the treatment is mainly just to make sure that we know what it is, and also treat it with radiotherapy. So just radiotherapy, just like a breast or a lung lesion would have radiotherapy from the outside. They would have basically what's like an X-ray, but targeted to the eye. We then move on to the intraocular tumours, and the symptoms and therefore the side effects of treatment for intraocular tumours really depend on how big the tumour is and where it's located. So if it's kind of near important structures like the optic nerve or the lens or the macula, and we'll come on to those terms in a minute, then they'll have much more impact on vision than if they're smaller tumours somewhere far away from those structures. Unlike other cancer services, we don't usually take a biopsy to make the diagnosis. We usually make the diagnosis based on what we see and all the scans that we do. And so biopsies are a little bit controversial in terms of making a diagnosis and treatment. A lot of centres don't really do many biopsies. Certainly in Liverpool we do, and they're mainly for prognostication, to see how likely tumours are to spread. And that's mainly because actually we've noted that we are treating smaller and smaller melanomas now, and actually the survival rate of those smaller and smaller tumours is much better than if you wait and watch them and wait for them to grow. So we're definitely treating smaller and smaller tumours nowadays rather than treating them with just watching and observation. So how do you treat these intraocular tumours? And the mainstay is basically melanomas. There aren't many other intraocular tumours that are common in the eye. About a quarter in Liverpool, I know Joe said a third, but we've kind of gone down with our enucleation rates, and I'll talk a little bit about why. About a quarter of our patients undergo enucleation where the eye is removed, and the other kind of majority are treated with some form of radiotherapy. So we talk about plaque all the time, and you'll hear about plaques. What's plaque? So plaque is a silver disc that's coated on the inner surface with a radioactive substance. And in Europe, it's generally ruthenium. In America, it's slightly different. And these plaques are placed on the eye, not inside the eye, but on the surface of the eye, underneath the tumor. So if this is the eye, the plaque is placed here, the tumor's here, and it irradiates that area over time. So this is a plaque coming out of the eye, and this is what they look like. So this is a 20 millimeter plaque. So these plaques are very good for tumours that you can see the borders, you know how big it is, and it will fit on a circular disc of a plaque. So you want something that covers that whole area with safety. And so this is what you see afterwards. You can see that the tumour's almost completely gone. Usually you have some tumour cells remaining, but they're all just dead cells now. And you can see that circle where the plaque was and treated with radiotherapy. And you get that circle because essentially what the plaque does is it kills off the tumour, but it also kills off that normal tissue around it. Just like we were saying earlier, most of the side effects are from normal tissue being destroyed at the same time as the tumour tissue being destroyed. Now, for this, this is fine because this area is not that important for vision. And so you might find that there's a little area in the periphery that isn't quite as clear and is a little bit greyed out, but it doesn't affect your day-to-day activities. And so for that reason, this plaque scar is not a big deal. And so again, if you have a small melanoma that's quite far away from, this is the nerve, this is the macula. The nerve is like the wire that connects the eye to the brain. And so without that, realistically, the eye can't see because the brain can't detect the vision that's going on. And the macula is where all the central detailed vision comes from. So if you can avoid those structures with any treatments, then generally the vision stays quite good. So a lesion down here that's quite far away from all of these works quite well with a plaque because you can see that circular scar around that tumour. What you don't want to see is this, where this plaque scar, this wasn't in Liverpool, I just hasten to add, this plaque scar was quite far away from the tumour, and also it's impinged on the macula a little bit, that central area of vision, so this patient's vision was not very good afterwards. The other form of radiotherapy is protons. Protons are excellent at treating small tumours in small spaces, so the eye is a perfect example of that. And the reason why that is because unlike X-rays, which can go from here all the way through into the brain, what the protons do is very focused, and actually the focus is about 2 millimeters. It's excellent. It's not quite as accurate as a plaque, but it's more accurate than any other form of radiotherapy that you can get from outside the eye without putting something on the eye. We're very lucky in the UK to have access to protons. There aren't many centres in Europe, and there's only one in the UK. We have patients really coming from Australia and New Zealand and the Middle East and places like that because they don't have any access to protons. So we're extremely lucky that we have this ability. It does need a little bit of prep work beforehand. So these are the little tantalum markers that we talk about. And these are non-magnetic, but you can see them on an X-ray markers that we put on the surface of the eye. And when you go to Clatterbridge, this is what they can see on the X-ray, so they can see where the tumour is outlined by the markers we've put on. They take lots of measurements of the eye. They can see where the markers are in relation to the tumour, and then they can make a 3D model of the eye to see what is the best way of treating this tumour and avoiding all the other structures that are important for vision. So if you have this tumour, you can have a beam that enters in this direction and hopefully avoids the nerve, avoids the lens, and avoids the macula is the plan. Protons are excellent at treating iris melanomas like this. This is an iris melanoma treated with protons, just because they're very, very small and they're much easier to treat with protons than they are with other forms of treatment. They're also very good at treating lesions near the optic nerve. So this is the optic nerve. Like I said, that's the wire that connects to the brain. That, like a wire, is like a cord that connects all the way to the brain. So if you can imagine trying to put a plaque on here, it's pretty much impossible because there's no space, and that's why protons are very good at treating this area. And also lesions that are under the macula or the fovea, where the central vision comes from. The problem with all of these radiotherapy treatments is that, again, they will affect normal tissue, so the nerve or the macula will be involved in the radiation field, which means vision in the long term will not be very good. And unfortunately, that is irreversible. The advantage of protons is it tends to be a bit gentler than plaques. So if you put a plaque on here, the plaques are more like quick burns. They cause very rapid, aggressive treatment to the tumour, but also aggressive side effects to places with good vision. Whereas the protons are more like slow crumbling of the tumour. So even though you do lose vision, it tends to be a bit slower and over a longer period of time. They're also very good at treating these kind of lesions that we're not quite sure where they start and where they stop and where the beginning is. And because with a circular plaque, you have to be very sure that it's going to fit on that circle. With protons, you can change the shape of the radiotherapy treatment and make it as wide or as triangular or as funny shaped as you like, really. And we're doing more and more bigger tumours with protons. With new drugs that are available, we're reducing the side effects of the radiotherapy. And so that's one of the reasons why our enucleation rate has gone down and our proton rate has gone up as we're treating bigger and bigger tumours. The problem with protons is that it doesn't give you that scar because it doesn't give you that burn. And so it's harder to monitor them. So you can see after a couple of years, you don't get that circular scar that you would with a plaque. And so you have to kind of monitor it on the scans a little bit rather than on the pictures. But obviously with bigger tumours, it's much easier to see because they do shrink with time. The other form of treatment is laser. There are different types of laser. Most of the lasers don't really work for tumours, but photodynamic therapy can do. And that's where we inject dye into the vein that goes into the blood vessels, into the eye, including into the tumour. And we apply a laser directly into that area that affects the tumour. Unfortunately, even though it does work, it has a much lower success rate than other treatments like radiotherapy, but it also has a much lower side effect profile. So this little melanoma very near the nerve was treated with photodynamic therapy because it doesn't really affect vision so much. Even though the nerve is there and the macula is there, the vision was actually quite good after the treatment because it's much, much gentler. The problem is it only works about 50% of the time, unlike the radiotherapy treatments, which work about 90–95% of the time. And so this is a tumour that was treated with photodynamic therapy, but continued to grow and eventually needed protons afterwards. So the main problem with any tumours is that they can come back, and that's probably why that is why we keep lifelong monitoring of all of these tumour cases. The ones that are most at risk of coming back are the ones at the ciliary body, which is right at the front of the eye. They're difficult to monitor because they're really at the front, you can't see them at the back. And sometimes they can grow in like a ring type fashion rather than just a lump. And that can be much more difficult to detect and treat. So this is a melanoma that probably actually went all the way this way, but we couldn't see that at the time. And then later on, after this area was treated, you can see a recurrence over this side. Some tumours are completely resistant to radiotherapy. It's quite rare, actually, but it does happen. So this is another melanoma that's treated with plaque. You can see the plaque scar there, and it grew quite a lot despite the plaque, and so then was treated with protons, and then grew again despite the protons. It's pretty uncommon, but if that's the case, unfortunately, the only treatment is to remove the eye. The other difficult ones to treat are the ones with kind of fuzzy edges, like I was mentioning before. You're not quite sure where they start and where they stop. And even if you treat this area, you can see that the recurrence is down here. So there must have been tumor cells down here that we couldn't see. And again, maybe this tumor had a little bit down here that we didn't treat, and there was a recurrence down here. So the ones that are a little bit fuzzy and a bit more difficult to see the edges of have a much higher risk of recurrence. It's always worrying when you see pigment appearing on the surface of the eye. If you've had a melanoma, you're always worried about recurrence. It's not always recurrence. It can be a number of other things as well. So this is a patient who had a plaque here at the front of the eye and got these little bits of pigment appearing. But actually, when we took a biopsy, we realized it was not organic. So what that means is that some bits of plaque, some bits of metal, some bits of rust sometimes come off the plaque, and you get this kind of inflammation around it, and they can cause little areas of pigmentation. This is another area of pigmentation, which again is not recurrent. So as the plaque is put on here, you can see that the normal sclera here is fine, and the sclera here is very thin because of the treatment of the plaque. And what that means is that white bit of sclera on the surface of the eye is so thin that you can almost see the dark layer underneath it. But again, that's not a problem. It's a benign thing. These ones are more difficult. So you've got these little bits of pigment that grow over time when you're worried about recurrence. But you can sometimes, as the tumor breaks down, get inflammation cells called macrophages that gobble up dead bits of melanoma cells, and they look pigmented, but actually they're just inflammation cells. But the only way you really can know that is to take a biopsy and look at it under the microscope and see what cells they are. These are, however, true recurrences. So you've got these areas that have grown over time, and you can see that there's areas of recurrence, and we took a biopsy, and it was definitely melanoma cells and not just inflammation cells. Again, this is another recurrence, and this is a lesion that recurs after a biopsy. And the last thing that can happen after plaque is that the sclera on the surface of the eye starts to degrade, just like we saw that the sclera was thinning on the other picture. Sometimes it can thin so much that it breaks down. That can be much more difficult to treat. And so sometimes we need artificial sclera called tutoplas that covers that area, and then you can cover the whole area of the top and just make everything a bit more secure. Again, that's very uncommon, but if it does happen, it can be quite difficult to treat, but it is treatable. Most enucleations that happen after radiotherapy don't happen because the tumours come back. They happen because of the side effects of the radiotherapy to normal tissue. So this is a patient who had protons, tumours breaking down, it's producing lots of toxins. It's caused the blood vessels in the eye to also shut down because of the protons, and all this yellow stuff is fat leaking out of those blood vessels that are leaking because they're so damaged. And realistically, this is one of the reasons why we end up with enucleation after radiotherapy, because of all the side effects of the radiotherapy, not because this tumour is still active, because the blood vessels have been affected, because the tumour is producing toxins, for example. Some of the radiotherapy around the nerve can cause damage to the nerve. This certainly would cause damage to the nerve. And sometimes this happens years after the treatment. And so this is a melanoma that's treated with protons, responded quite well. But you can see after a couple of years, this nerve is not looking very healthy at all. It does cause problems with vision. And unfortunately, even with the newer treatments that we have, usually it's pretty irreversible. The issues with blood vessels, again, you can see over time, this is 10 months after protons of this very small melanoma. You can see all these little swollen areas of the nerve. It's bleeding a little bit there. And then you can see these blood vessels start looking very unhealthy to the extent that this patient then got a bleed in the eye. We went inside the eye with keyhole surgery, cleared out all the blood, did some laser to stop it bleeding again, and now it's stabilized, but the vision is not very good. You can see all these blood vessels that were full of blood here are now not really full of blood anymore because of the side effects of the radiotherapy. And the most common side effect of treatment is what's called macular. It gets very swollen with the radiotherapy. So these are kind of slices through the retina, and this is what the retina should look like. and in the middle you can see all these kind of black cysts because it's very swollen. It's like a big bruise. And we can treat that with injections into the eye of different new agents that we've got nowadays. Anti-VEGF is the most common. It's used for macular degeneration as well. That's where it started off. And with steroids, we can see some of these swollen areas look a bit better after injections. And you can also, so aflibercept is one of the newer drugs that we're using, and you can also use steroids. So this is a steroid drug that's used. Unfortunately, even though we can get rid of a lot of this swelling, about 70% of patients respond to injections in the eye. Of that 70%, probably about half of them get better vision afterwards. So even though this looks better and less swollen, the vision may not improve, but it's definitely worth a try. And the last easiest thing to treat is cataracts. And so if you have radiotherapy to this area in the eye, you can get cataracts, which is where the lens goes a bit cloudy, and cataract surgery is reasonably routine. We can get that done and sorted. The last treatment is enucleation if the tumour is too big. The advantage is that you don't get all these side effects and you don't get all the pain, but you lose vision immediately, obviously, because the eye no longer functions at all. The main side effect, which happens in up to half of cases, is what's called phantom eye syndrome. It's a bit like phantom limb syndrome. You know, veterans who've had their legs removed, for example, can sometimes still feel their legs, and sometimes it feels like it's itching. It's a bit like that, where even though the eye's been removed, patients can still see things, and it's not reality. They sometimes see patterns and shapes and sometimes people, and if you don't ask about it, often they don't offer up these symptoms they're having because they think they're going a bit nuts, and they're not going nuts. It's just the brain trying to interpret what's going on in that area with the nerve that's left. And so the brain kind of interprets all these random kind of messages from the nerve that isn't connected to an eye anymore as patterns and shapes. And once patients know that that's the reason, they feel a lot happier about it. And actually these visual hallucinations, we call them, but they're not really hallucinations, are usually quite nice. You sometimes get like floral patterns and things. Once you know that it's not because you're going mad, I think they're actually quite nice usually. So this is the Liverpool Oncology team. Obviously, if you have any questions or concerns or worries or anything, we're always available to help and offer advice. So that's me done.
Perfect. Thank you, Dr. Rumana, Dr. Hussain. Sorry. Okay. Well, I mean, I've got some questions that we got ahead of time, but if you have any questions and are listening live, please do type them into the chat box, and we can pick up any that we can't get to and come back to you all separately. So please do ask any questions over in the chat box, and we'll try and get through as many as possible. Okay. So if it's okay, Rumana, I'll just quickly ask a few questions.
No problem.
Okay, so I have a small choroidal melanoma on the macula, currently being treated with proton beam. I've just noticed that I have what appears to be 2 grey/blue specks on my iris. They have probably always been there, but I've never looked that closely at my eye. I've only ever seen it after the doctors were, sorry, I've only ever seen it after my eyes were dilated. Would they show up on a scan like an OCT or a fundus?
Not really. So,
Okay.
so iris lesions are really common. Actually, if you look close enough, most people have little freckles and things on their irises, and quite often we don't notice them well, for a long time in the ocular oncology units because patients are always dilated by the time they come to see us. And so if you have noticed anything like that, I would recommend that when you go see them the next time, they take some photos before you're dilated and keep a watch on them. Like I said, they're not related to the melanoma at all. It's far too far away from the macula to be kind of seeds of the tumour on the surface of the iris, but it is definitely worth keeping a note of them and watching them and make sure they don't grow over time.
Perfect, thank you. And I think this question might be a bit difficult, but can I ask what it's about recurrence and how often an eye can be treated and which treatments can be repeated?
It kind of depends on the location and the size of it, Joe. So if you have you kind of, I showed you a picture of a very small recurrence of a conjunctival tumour, and we excised it and put a plaque back on because it's very easy to just put a plaque on that area. And again, if you have someone who's had an area treated and it's a small area of recurrence in a very localised area, you can either treat it with a plaque or maybe with laser or something like that. Unfortunately, with the ones that tend to recur most often are the ones that I showed you that have kind of foggy, fuzzy edges. And if that happens again, it's very difficult to guarantee that we'll get it all this time round as well. And so it is, all of our decisions are based with having a chat with whose eye it is, which is you guys, to see what you want to do. And if you want to try again, we can always proton again, we can plaque again, we can do all these things again. But every time there is a recurrence, there is a risk that we still don't manage to catch up with it.
Lovely. And if a melanoma is near the optic nerve and continues to grow, will it eventually invade the nerve, and what impact would that have?
It can do. So this is the worry about melanomas next to the nerve, is that it is easier for them to escape the eye down the length of the nerve. And so even though it's actually not common, particularly in smaller tumours, that is the worry, is that if it's left and left and left, that it grows posteriorly behind the eye. And unfortunately, if that happens, not only is the vision compromised with any treatment, but it would have been anyway, once the tumour leaves the eye, the chances of it spreading to other places is much higher. And so ideally, you'd want to treat it before it ever got to that stage.
Okay. And if the tumour is over the optic nerve, somebody's had proton beam therapy and they do then get their eyesight is affected because of the treatment, are there any related regeneration trials that could restore some of the sight?
Unfortunately not. The radiotherapy is designed to really quite aggressively kill off tumour cells, and therefore also quite aggressively kill off the nerve cells as well. It's a bit like having glaucoma. If we could reverse it, because that affects the nerves as well, if we could reverse that, then we would be looking at similar things. And there's lots of research going on into whether you can get neural regeneration, but just like, because the eye is an extension of the brain, just like with brain problems like Alzheimer's or nerve problems like glaucoma, unfortunately, we're not anywhere near that yet.
Okay, and then the last one from me, just before we move over to a couple that's in the chat. Question from a family member. My child is a teenager and has an ocular melanoma. It was treated early and was reduced in size since treatment. How can a parent ask difficult questions without their child being present?
So certainly for Liverpool, we have lots and lots of specialist nurses around. And so whenever I've had children who've had ocular melanomas, I will normally kind of send the child off with one of the nurses to go have a chat with, and they can also voice their concerns on their own and have a chat to the parents on my own. I think I do have a chat to the family as a whole, but then I will have a little chat separately with the parents afterwards.
Lovely, thank you. Okay, well, if we head over into the chat box, we've got a question from Rosie. How often does double vision occur after plaque?
Oh, that's a really good question, Rosie, because we're just looking into that right now. We kind of quote 10%, but I don't know if that's really true. And of that 10%, we also quote that most of that is temporary and about 10% are long-term. But we're literally in the middle of looking at that with our orthoptic colleagues. So ask me in a year and I'll give you a bit more of an accurate answer to that. But that's what we say.
Fantastic. And then a comment from Wendy. We haven't touched on stereotactic radiosurgery. Are you able just to give us a quick couple of liners on that, just for time?
So stereotactic is slightly different. Sorry, I didn't mention it at all. So we don't offer it in Liverpool just because we haven't set it up, but the only place in the UK that offers stereotactic really is Sheffield. It's very good for big tumours where essentially the alternative might only be enucleation. The reason why it's not very good for other tumours, smaller tumours, is because unlike protons, which is very localized, stereotactic is not very localized. It treats the whole eye. And so essentially the vision afterwards is not very good. And quite a high proportion of patients end up losing their eye because of the side effects of such a high dose of radiotherapy. So normally we would recommend it for patients who can't go through the other forms of treatment like protons. So if they have a big tumour and realistically they can't have a general anaesthetic to have their markers put in, they can't travel so far to Clatterbridge to have their protons, then we'd talk about stereotactic. So it's kind of a backup radiotherapy. It works very well, it kills off tumours excellently, but it has significant side effects.
Perfect. Well, I think nearly bang on time there, and really well covered. So thanks again for your time today, for answering all our questions.
Have a good rest of
brilliant.
the day, everybody. All right.
Fantastic. Thanks very much. Bye-bye.
No problem. Bye now.